Hi guys. As they've mentioned, my name is Meenakshi Ramanathan. I'm an infectious diseases clinical pharmacist and associate professor here at the University of North Texas. And today's topic is how many pills are too many, a discussion of medication burden and mitigation strategies. For my disclosures, I do hold some stock of what is remaining based off of how the market is doing, but I do own some stock in some of the medical companies, so I do have them listed right there. And on the next slide, I have my session learning objectives for today. Today we're going to define medication-related burden and polypharmacy, and actually also hyperpolypharmacy. We will also look into describing tools to assess medication burden, and then talk about mitigation strategies to reduce medication-related burden as well. So if we're looking at the epidemiology for medication burden and also polypharmacy, and this will probably speak to a lot of you that are out there, technically 91% of our long-term care facility patients fall underneath the bucket of polypharmacy, and I will define that on the next slide. And for patients who are on more than 4 medications, they are at an increased risk of falls, which puts them, if they do have an injurious fall, they do put them at a risk of getting more medications because of that fall. Some data that I did find in terms of polypharmacy was that of patients 65 years of age and older in America, if we look at the years between 1999 to 2000 and 2011 to 2012, there was an increase from 24% to 39%. Of course, 10 years have passed since then, but I'm sure there's a lot more that we are seeing these days. And 1/5 of older adults will receive at least one medication that will adversely affect one coexisting condition that they already have. And having hyperpolypharmacy is associated with an increased risk of hospitalization, despite the number of comorbidities that the patient might actually have. Next slide. So when looking at the definitions for these various terms, medication-related burden or treatment burden refers to the overall workload that is imposed on patients resulting from utilizing healthcare, leading to multiple negative effects in their lives. I know I felt this recently because we've had a long slew of RSV and influenza A in my family over the past 3 weeks. So I can totally relate to the medication-related burden or having to deal with healthcare over this time. But if you look at the polypharmacy definition, it's the use of 5 or more medicines. I will say there is no clear-cut definition for polypharmacy, but this is the most commonly used definition for polypharmacy. And then when I was doing my research, there's also a term called hyperpolypharmacy, which is the use of greater than or equal to 10 medications, which when I was working outpatient at Parkland Pharmacy, outpatient pharmacy, which is Dallas County Hospital, it's very similar to JPS here in Fort Worth. Most of my patients who were elderly were on 10 to 15 medications. So I would have to say most of our patients who are in long-term care facilities, if they are not polypharmacy, they may also be hyperpolypharmacy as well. Next slide. There are lots of clinical consequences of polypharmacy, as you guys already know. The most common ones that they talk about in the literature is falls and hospitalizations. From a pharmacy standpoint, we tend to think of drug-drug interactions with more medications that the patient has to take, medication non-adherence, inappropriate prescribing, adverse drug events, functional decline overall, mortality. Another one that people tend to talk about with polypharmacy is financial hardship. And I know a lot of us are feeling the pinch already with the inflation that is going on right now. But the financial burden of polypharmacy is also something that we worry about. Patients who have are considered to have polypharmacy are definitely at an increased risk of adverse medical outcomes overall. I saw this cute cartoon that I wanted to add. It says the lab where they study drug interaction, and they put the pills next to each other, and some of them are excited and some of them are angry at each other. So I just wanted to put that one in there. Next slide. There are various risk factors that we worry about for polypharmacy. Of course, one of them being in the geriatric population. This paper that came out of AAFP said that patients aged older than 62 years, cognitive impairment, developmental disability is also there, especially in the younger populations. Frailty, lack of a primary care physician, and not only a lack of a primary care physician, sometimes when you have also multiple subspecialists that may not be communicating with each other, and providers not wanting to discontinue medications that were prescribed by other providers. Mental health conditions, multiple chronic conditions, such as pain conditions, diabetes mellitus, coronary artery disease, cerebrovascular disease, or cancer, where the patient might need to take multiple medications as per the guidelines for those disease states, residing in a long-term care facility, as most of our patients are. And then from a healthcare system standpoint, poor medical record keeping, and that also includes the patient's medication profile at the pharmacy, poor transitions of care, which I know we're having a transitions of care talk next week. So that's very important in terms of transitioning the patient from the hospital to long-term care facility or vice versa. Prescribing to meet disease-specific quality metrics, and use of automated refill systems. And again, that goes back to having an updated profile at the pharmacy and discontinuing out any medications that the patient is no longer taking, so that it does not get automatically refilled. I will give you an instance of my husband's grandmother. Whenever I would go back to India, I would review my my grandparents' medications, and she was taking 2 statins. And I said, no, why are you taking 2 statins? And they gave her both of the statins, and she was taking them. So that's something where we do want to pay attention, that if we're starting a new medication, that we remember to stop the older medications that are no longer needed. Next one. So you've probably seen multiple cartoons that are out there like this, but it's a never-ending story. If the drugs do cause a problem, then we've got some pills that might help, and some other pills for the side effects of the pills you take for the problems the drugs cause. So of course, you might be taking the medication to help with a certain disease state, but those pills may have adverse effects associated with it that you need to take another medication for. So most commonly, I guess one example would be for opioids, we had to take stool softener, right? So there's an example right there with adverse effects, where it's a never-ending story of us adding more pills where maybe it's not necessarily needed. Next slide. There are various high-risk medication assessment tools that are out there. The clinicians that are on the call are probably more familiar with these. So Beers criteria has been around for quite some time now. The latest one that was released by the American Geriatric Society was in 2019, prior to the pandemic, and they have the long version that you can download from their website, but they also have a pocket card that talks about different medication groups that you should avoid in the geriatric population. There's also the stop and start criteria, which stop stands for screening tool of older people's prescriptions, and start stands for screening tool to alert to right treatment. And this is another set of tools that can be used in terms of telling us which medications to stop and which medications to start in the elderly population. Another medication appropriateness tool is the Medication Appropriateness Index, which they have a free version of this tool on the website Global RPH. And essentially this tool is a 10-question tool that each question, they tend to score anywhere from 1 to 3, with a maximum score of 18 depending on the question. And the types of questions that they have on here is there an indication for the drug? Is the medication effective for the condition? Is the dosage correct? Are the directions correct? Are the directions practical or capable of being put into practice? Are there significant drug-drug interactions? Are there clinically significant drug-disease condition interactions? Is there unnecessary duplication with other drugs? Is the duration of therapy acceptable? Is this drug the least expensive alternative compared to others of equal utility? So again, the maximum score on the medication appropriateness index is an 18, with a 3 being considered an inappropriate medication. And you'd run through those 10 questions for each medication that the patient was on. Next slide. There are also assessment tools that are out there for specific medications based off of pharmacologic effects. So the most common bad drug that we talk about in the geriatric population is, of course, our anticholinergics. So I'll show you the anticholinergic cognitive burden scale on the next slide. But there's also medications in terms of like the sedative load or the drug burden index that can also be used. So on the next slide, we have the anticholinergic cognitive burden scale, which basically groups these and anticholinergics into subgroups in terms of possible anticholinergics versus definitive anticholinergics. So the ACB score of 1 is a possible anticholinergic, and an ACB score of 2 or 3 is a definite anticholinergic. And so for each medication that the patient is on, you would add up the scores to get the patient's anticholinergic cognitive burden scale. And basically, may increase the risk of cognitive impairment by 46% over 6 years. And for each 1 point increase in the ACB total score, a decline in MMSE score of 0.33 points over 2 years has been suggested. Additionally, each 1 point increase in the ACB total score has been correlated with a 26% increase in the risk of death. So we do want to pay attention to the overload of anticholinergics in our geriatric population. Next slide. Now, there is an argument that we always, whenever we say polypharmacy, there is a negative connotation to the term, but it may not always be harmful. There are papers out there saying that polypharmacy may be appropriate in the setting of multimorbidity, where the patient needs to be on multiple medications for that disease state. So that's where we get into the dilemma, is when we treat patients based off of treatment algorithms from the guidelines, sometimes multiple medications are needed to control the chronic condition, whether it's diabetes or heart disease. So then what do we take off in that instance? Next slide. There were 2 Cochrane reviews that were done on the polypharmacy topic. The first one of this is an update. The first one was done in 2014, and this is the 2018 update. So the topic is interventions to improve the appropriate use of polypharmacy for older people. And when I read the results of this as a pharmacist, I was actually quite sad because the author's conclusion on this topic was, it is unclear whether interventions to improve appropriate polypharmacy, such as review of patients' prescriptions, resulted in clinically significant improvement. However, they may be slightly beneficial in terms of reducing potential prescription omissions, but this effect estimate is based only on 2 studies, which had serious limitations in terms of risk bias. So we still don't have an adequate definition for polypharmacy, and we also don't have adequate assessment of polypharmacy or deprescribing to be able to tell whether it does have an impact on the patient or not. Next slide. So there's the Choose Wisely campaign, which has been promoted by 3 societies, including the American Geriatric Society and the American Society of Health System Pharmacists. And their recommendations from a pharmacology standpoint is that if the patient is currently on 5 medications or more, you want to make sure that we do not prescribe any further medications without, doing a appropriate review of the existing medications, over-the-counters, dietary supplements to just determine whether the medications need to be continued or discontinued. And then similarly, the American Geriatric Society is saying do not prescribe a medication without conducting a drug regimen review. Next slide. So deprescribing is a term that is often used as the remedy for polypharmacy. And the definition for this is a process of withdrawing inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving patient outcomes. There are three primary goals associated with deprescribing. So evaluate the appropriateness of prescribing, reducing inappropriate polypharmacy, and also improving patient outcomes from a morbidity and mortality standpoint. Next slide. There are various strategies for deprescribing that are out there. These are some examples that have been given in the literature. So like the ACB score, you can target specific medications, so anticholinergic, sedatives, or you can target specific patient populations, like the geriatric population, or patients with disabilities, or that type of thing. You can also use computerized clinical decision support systems. So I believe you guys still use Epic or NextGen, and sometimes those systems will automatically roll off medications that have expired in the system. So you can use those tools to target specific medications or patient populations, or help you in terms of computerized clinical decision support systems. Next slide. The other thing that you could do is also, if you have access to a pharmacist, please use your pharmacist. If you have a clinical pharmacist or an ambulatory pharmacist in your clinic, they can help you with medication reconciliation. I know we do. We were using pharmacy technicians in the emergency department to help with the medrex, because that always more accurate from a pharmacy standpoint. Medication therapy management is also there, which I'll go over in the next couple of slides. Use of an assessment tool to detect medications known to increase their risk of adverse effects. So pharmacists will run drug utilization reports when we're filling patients' medications, but there are data mining software tools like Theradoc, Sentry7, Pharmacovigilance that can alert the provider or the pharmacist to different interventions that can be done on the medications. And of course, the most common ways to help with polypharmacy is by reducing pill burden by removing unnecessary medications, reducing dose or dosing frequency of a medication, and then if there's availability of combination products for which the patient's already on, consider using a combination product. Next slide. So APHA, the American Pharmacists Association, has a medication therapy management certificate, which a lot of our students in the pharmacy school actually get. And the medication therapy management focuses on 7 drug therapy problems that we tend to look at on a daily basis. And this is usually related from reviewing indication to effectiveness, safety, and then also adherence. So the 7 primary drug therapy problems is matching up the disease states with the patient's medications and determining if there is an unnecessary drug therapy or if a patient needs additional drug therapy, effectiveness of the medication, of whether the dose is too high or too low, or if the medication needs to be switched, adverse drug reactions, drug-drug interactions, and of course, adherence as well. Next slide. Of course, the deprescribing needs to come from a holistic approach in terms of the whole team. And remember that the patient is part of that team in terms of deprescribing, because some patients may not, they may feel that their medications are helping them for their chronic conditions. So you need to make sure that you get them on board as well for the deprescribing. So the approach for the shared decision-making that is common out there is the SHARE approach. So you seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, reach a decision with your patient and evaluate your patient's decision. And if your patient is cognitively impaired, sometimes you'll also need to make sure that you get the patient's family members on board or power of attorney on board in terms of the deprescribing. Next slide. So there's a lot of different questions that you can ask yourself. Are there are these pain medications necessary? Are they efficacious? So these are just some example questions. If supplementation is needed, is based on the patient's lab, is the supplementation still needed? Is the PPI still needed? Because sometimes patients get put on PPIs when they're in the hospital and then they come outpatient and they're still on the PPI. Is the statin still necessary for that patient-specific age group? If they're on a multiple dose product, can we switch it to a once daily product? Or are there certain medications that can be given in combination products? Or if a medication is not efficacious or has an increased risk of causing adverse effects, can it be removed from the patient's profile? Next slide. So resources for deprescribing include, of course, Beers criteria. The Canadian Deprescribing Network does have their own set of guidelines and algorithms that you can also access. Epic and NextGen will auto-discontinue expired medications to reduce the risk of polypharmacy. You can run drug-drug interaction reports on various pharmacy platforms like Epocrates. At UNT HSC, we have LexiComp and Micromedics access as well. And then MedStopper is a website that will help give you suggestions on which medications that you can possibly discontinue or switch. Next slide. So some key points to take away from today's session. Physicians should identify and prioritize medications to discontinue and discuss potential deprescribing with the patient. When deprescribing, always develop a specific follow-up plan with the patient. And then once medication reconciliation and deprescribing plan has been put into place, you want to revisit the plan at every visit. And before starting any new medication, consider underlying causes to treat first, necessity of treatment, alternate non-pharmacologic treatments, and benefits versus risks of treatment. When starting a new medication, consider a trial rather than a permanent addition. And then when refilling medications, consider the benefits versus the risk of continuation in the short term and long term for that specific patient. Next slide. To tie everything up, there's no uniformity in terms of the definition of polypharmacy. Again, the most common definition is being on more greater than or equal to 5 medications. And there's also not a common way of actually assessing polypharmacy as well. Deprescribing will involve a multimodal intervention approach, which will include all of your healthcare team members, including the patient. And reducing the medication-related burden and polypharmacy can improve the patient's quality of life and reduce hospitalization and the risk of falls. So that concludes my talk today.